Good evening, everyone. On the behalf of Team Dentist Channel Online, I would like to extend a very warm welcome to all of you on today's session on the topic Demystifying the Basic Implantology by Dr. Anuj. I'm Dr. Aditi Mishra, and I'll be the host for today's session. So, before starting the session, I have few housekeeping notes to make. If you have any doubts during the session, you can drop your questions in the question and answer box, and each and every question will be taken up at the end of the session. If you have joined us from Facebook and YouTube Live, you can ask us questions by commenting, and we'll be answering them at the end of the session. So, without further ado, I would like to introduce our today's speaker to everyone. Dr. Anuj is the consultant and oral and maxillofacial surgeon in Kinder Hospital, Kochi. He has also been a consultant oral surgeon in KIMS Hospital, Kochi. He is consultant oral and maxillofacial surgeon in HGM Hospital, Kottayam, and he has been serving as assistant professor in Kannur Dental College. He has done certificate course in clinical implantology from Brainmark Center. He has done certificate course in pterygoid and zygoma implantology from Institute Implantology, Hyderabad. He is the rank holder PG exam, Kerala Health University, consultant implantologist at various clinics in Kerala, and he has expertise in all on 4 and 6 implants, sinus lift, zygomatic, pterygoid implants, and he is the founder of Kerala Dental Academy. Over to you, sir.
Good evening. I am Dr. Anuj. Am I audible?
Yes, sir.
My screen is sharing.
So right now it's not.
So I have to start it or?
Yes, sir.
One minute.
Can we go on full screen mode, sir?
Yeah, I'm doing it. 1 minute. No. 1 minute. I have to stop there and then I will do it again. 1 minute.
Meanwhile, I'll introduce our participants that we are starting one comprehensive implantology course in Kochi, and all the details will be given by Dr. Anuj. And this course is starting on 6th of January till 9th of January. And during the session, Dr. Anuj will be guiding you regarding the course.
One minute. Hello. Hello.
Yes,
Hello.
sir.
Is how's screen? Is it in full screen mode?
Yes, sir. Yes, sir. Please go ahead.
Okay. Thank you. Sorry for the delay. I'm Dr. Anuj. I'm consultant online maxillary surgeon in Kinder Hospital, Kochi. And today we will be dealing with the basics concepts of implantology. Implantology, we will discuss only the basic topics. The basic, what all you need to know before doing implants. And a generation of dental implants. Usually, the replacement of a missing tooth was present from centuries. And as the science and the technologies in dentistry advance, the formation of what new methods arise, and lifelike restorations for missing tooth were born. And in the early ages, dental implants were a rare option for replacing lost tooth. And nowadays, the replacement of lost tooth with dental implants have become more common, and it restores the function and appearance of the lost tooth. What is a dental implant? A dental implant is simply a alloplastic and biocompatible material which is placed into, which is means endoosseous or onto, that is just below the subperiosteum. It's not a subperiosteum, the jawbone, to support a fixed processes or to stabilize a removable process. So dental implant is highly biocompatible material, and it's an alloplastic material, that is by artificial means. Okay, so and it's can be placed into the bone or just below the periosteum. These are the commonly used types of dental implants. And Professor Brainemark is considered to be the father of modern dental implantology. And he was the person who introduced the dental implant practice into the world. And he discovered the dental implants, that is the concept of dental implantology, while doing his experiments in a rabbit. He was an orthopedician. In 1965, he was doing his usual experiments in rabbits in his lab, and he found out that the implants made of titanium, when we have any fractures or facial bone fractures or a fracture of our shoulder bones or leg, we usually fix the fractures using implants, which are basically titanium implants. Earlier it was stainless steel implants. The problem of these stainless steel implants are they are biocompatible, but their chance of infection was more, and so we have to remove it after some time. With the advent of these titanium implants, when he re-entered the leg of the rabbit, which he placed the titanium implants, there was coverage of bone over the titanium implants. So he found out that the implants made of titanium is more biocompatible, and it allows the growth of bone over the implants. So he thought of using the titanium implants for replacing missing tooth. And according to him, no one should die with their teeth sitting in a glass of water. And he did his first dental implants in a Swede named Gustav Larsson in 1965. And he introduced the phenomenon of osseointegration. Am I audible?
Yes, sir.
Yes, thank you. And we have various options like fixed processes of like FPD, and we have removal processes, RPDs, and there. So why we should use this dental implants? What is the benefit of using dental implant instead of all these? The dental implants anchors or it osseointegrates the jaw bones, and it prevents further bone loss. In the case of fixed partial denture, we are reducing the tooth surface area of two adjacent tooth, and we are making the processes. There is no connection with the bone. In the case of dental implant, we are placing the dental implant in the site of missing tooth. So the area of the bone is filled with the dental implants, and the bone grows over the dental implants. So it prevents the further bone loss, and it restores the function and aesthetics of the overall maxillofacial processes. And it offers the best and most preferred option for stabilizing loose dentures. If you have a lower denture, the patient is a denture wearer for a long time, and with advancement of this option, the patient the denture becomes loose. So what we can do is we can use the implant to give over denture, and it offers is the most preferred option for stabilizing loose dentures, and it's only option to deliver fixed processes in cases where conventional FPD is not feasible. Then you will be thinking in what all scenario the conventional FPD is not possible. In the cases where we are having distal extension cases, because if you are having a missing tooth 6, 7, 8, then we can opt for only implant, that is a fixed option, or we can use for a precision attachment, that is a semi-fixed. But if you want a fixed option in distal extension cases or in very severely atrophied ridges, the only fixed option is implants, and it's the strongest and long-lasting treatment for replacement of a missing tooth. It's not affected by the other factors. Basically, the bone and the implant also integrates, and as a result of this, it's the most strongest and long-lasting treatment. And in the case of patient having dentures like maxillary or mandibular dentures, it's very disturbing for annoying for the patient for having phalanges, palatal extension. Many patients find it uncomfortable. They will feel like have not able to sense they lose their taste of the food.
100 seconds out.
Hello. Hello. Hello.
Yes, sir, you're audible.
Yeah. Okay. And we can avoid these palatal extensions and deep flanges in the mandible dentures with the use of implants. If we are giving a process is supported by the implants, we can avoid the palatal extension and the deep flanges of over the buccal and the lingual extensions of the dentures. So it will be comfortable for the patient. So the basic concept of implant turns around the phenomenon of osseointegration. What is osseointegration? Osseointegration is simply the direct structural and functional connection between ordered living bone and surface of a load-carrying implant. This is the definition given by Brainmark and his associates in 1986. And in 1986, Steinman and his associates simplified this definition as a direct contact between bone and implant surface. Immediately after the implant is inserted into the jaw bones, the peri-implant bone, that is the bone, this one is we have placed the implant and there is bone around. And once we do the osteotomy, that is the preparation of the bone to receive the implant, that is the osteotomy site, it will be filled with blood, and like our extraction socket healing, there will be entry of macrophages, the polymorphonuclear neutrophils, and the plasma cells, and all these work together, and there is formation of osteoblast and osteocytes. The osteocytes results in bone resorption, and osteoblast results in bone formation. And by this, the bone grows into these grooves of the implant, and then the implant osseointegrates. And it takes up to a period of about approximately 3 to 6 months. It varies from the condition to condition. That is, in some cases where the bone is very less dense, it may take some more time. So in each scenario, the time taken is different. That is, if you are doing any bone grafting, time taken will be more. Okay. So within a period of 3 to 6 months, it reaches the dynamic equilibrium. That is, it has its strength. And within this period, we will do the process, that is a crown or a bridge. Although the dental implant clinically resembles like the natural tooth, it differs from the natural tooth in many factors. The natural tooth has the periodontal ligament fibers all around the root, and these periodontal fibers act as a cushioning, like it acts as a shock absorber for the occlusal load applied onto the tooth, and as a result of this, it's not directly transmitted onto the bone. That's a shock absorber. In the case of implant, it is directly also integrated to the bone. So there is no shock absorber effect. If there is any force that is applied onto the implant, it is directly transmitted onto the bone. And also the periodontal ligament fibers gives additional blood supply to the bone and the tooth. In the case of implant, it has only blood supply from the periosteum and from the connective tissue. And it does not have any connective tissue attachments to the implant collar. And so we should not do any inadvertent circular probing that we do usually do to know the sulcus depth and all in the natural tooth, we should not do in the case of implant. It may lead to resorption of the bone. And we should also have adequate thickness of the peri-implant soft tissue, that is circular epithelium and everything, to have a good post-operative health of the bone around the implant. If the thickness of the soft tissue is less, there is more chance of peri-implantitis and more chance of accumulation of plaque, and then may lead to peri-implantitis. And resorption may occur around the crust of the bone of the implant. So, the osteogenesis or the process of osseointegration, it occurs by two methods, that is through contact osteogenesis and distant osteogenesis. Contact osteogenesis is the osteogenesis that happens along the surfaces of the implant, and distant osteogenesis is the formation of bone which occurs in the osteotomized bone. That is, we have prepared the bone, we have osteotomized it, and here the bone formation occurs from here to the implant. And combination of these two, that is the contact and the distant osteogenesis, result in osseointegration. So we have discussed about the basic concept, that is how an implant osseointegrates. That's the basic concept of implantology. And before doing any procedures, we should know about the anatomical structures. Doing implantology practice is not a complicated procedure, but we have to know about the anatomical structures, and a clean and patient surgery is the key to the success of any procedure. So basically, we are dealing with the maxilla and mandible. So we'll be discussing only about the maxilla and mandible. In the case of maxilla, what all structures we have to be considered? That is the nerves. The main nerves are the posterior superior alveolar nerve, the infraorbital nerve, and the anterior superior alveolar nerve. The posterior superior alveolar nerve, it supplies the sinus, molars, the buccal gingiva, and the adjoining portion of the cheek, and it arises from the pterygopalatine fossa and it forces downward. And we do any sinus lift procedure, we may encounter the posterior superior alveolar nerve. Infraorbital nerve, it arises from the pterygopalatine fossa. It's a branch of trigeminal nerve, and it exits through the infraorbital foramen. In the case of severely resorbed ridges, if we are not cautious while doing the reflection of the flap, we may result in injury of the infraorbital nerve. And the other thing is anterior superior nerve, that's the terminal branches of the infraorbital nerve. Then the main thing is maxillary sinus. The maxillary sinus is the main anatomical structure which prevents or which limits the placement of implant in the case of posterior maxilla. In the case of replacement of tooth in the premolars and molars, the pneumatization of maxillary sinus results in the lowering of the level of maxillary sinus to the alveolar ridge. In the case of available bone height is very less, we have to do either sinus lifting procedure and do the sinus grafting, or we have to do sinus bypassing using tilted implants. Like we can place the implant on either sides of the sinus by giving pterygoid implants or zygomatic implants or nasal implants, and then replace it. So we have to know about the position of the maxillary sinus. In the case of mandible, we have to only worry about the mandibular nerve. The mandibular nerve, it comes from the mandibular foramen, and it enters the mandible through the mandibular foramen and runs through the mandibular canal. And the location of the mandibular foramen will vary from patient to patient. So we have to be cautious about the position of the inferior alveolar canal in the region of molars, second molars, and first molars, basically. And the case in patients, it may vary from some patients it may be elliptical. In some patients it may be linear. In some patients it may be spoon shaped. It varies depending upon the curvature of the a neurovascular bundle. And in cases where there is more curvature is there, it's very favorable for placement of the implant. And it exits through the mental foramen and it gives incisive branches. Usually, in most of the cases, looping of the mental nerve we may encounter looping of the mental nerve in some cases. Looping of the mental nerve means the mental, that is the mental nerve exits through the mental foramen and it may course forward and then it may course backward and superiorly and then it exits as incisive nerve and gives the branches. So while replacing the premolars, we should consider about the looping of the mental nerve. And in the case of posteriors, we should give a safe distance of about 2 mm or 3 mm. 2 to 3 mm is better from the inferior alveolar nerve to avoid injury to the inferior alveolar nerve. These are the basic anatomical considerations that you have to keep in mind before doing your implant surgery. So you have understood about the basic anatomy and all things. But before doing any practice, implant practice, we should know about the density of the bone, because the density of the bone is varied in the case of maxilla and mandible. And the first one is Lecomann's classification, and he classified as quality 1, 2, 3, and 4. Quality 1 is homogeneous compact bone. In quality 2, there is a thick layer of compact bone, and there is core of dense trabecular bone. In the case of quality 3, there is a thin layer. The thin layer is thin cortical bone, and there is a dense trabecular bone of favorable strength. And in quality 4, there is very thin layer of cortical bone surrounding a core of very low dense trabecular bone. And this is the classification given by Kalmish. Kalmish classified as D1, D2, D3, and D4. D1 is a type 1 bone, is very dense cortical bone. We usually found it in the anterior mandible. And it's highly dense. And when we do the osteotomy with the drills, usually we do the preparation of the implant osteotomy site using drills. And we should use, we do the preparation using a physio dispenser. And the physio dispenser has a continuous flow of saline to reduce the blood formation of heat or generation of heat. So in the case of doing a D1 type bone, we should do the preparation high speeds with continuous flow of chilled saline. And we get the highest primary stability. Primary stability is when we place the implant, we are torquing it into the bone and we get a resistance from the bone. And in the case as it is highly cortical, we will get maximum resistance. So our primary stability will be high. But the main problem is if we do our preparation not in a correct manner, there is excess formation of heat. Heat generation may lead to heat necrosis and loss of bone and failure of the implant. And the second one, that is D2 type, or it is a dense cortical and thick cortical and coarse trabecular. That is, the bone shows a thick layer of cortical bone around it, and in the central portion there is a dense trabecular bone, usually found in the anterior mandible, anterior maxilla, and in posterior mandible also. And the case it's favorable for the implant placement. At the crustal level, we are having highly dense bone, and the medullary bone, it's dense trabecular bone. And here the preparation can be done at a speed of about 1000-1200 rpm. And in D3 type, it's a thin, porous cortical, thin and fine trabecular. You can see that the space between the trabeculae increases. Here it was dense. Here it becomes fine trabeculated. And it has high vascularity and high osseous healing is there. And it gives some sort of primary stability. Good primary stability is usually found in the maxillary anterior region, maxillary posterior region, and in sometimes in mandibular posterior region. And D4 type or fine trabecular, here the trabeculae are very far apart. This has an unfavorable strength, low density. And the thing is, when we do our preparation, it should be done at a slow speed, and we get very less primary stability in the case of D4 bone. It's usually found in the posterior maxilla. And we may encounter highest rate of prosthetic failure in the D4 bone. And how we can overcome the low density with the problem with the D4 bone? We have to under prepare it. Suppose we are doing our implant placement size is about 4.5 mm, we will prepare to about 3 mm or 3.5 mm, and then we will torque it. So we will get a better primary stability than preparing at the same diameter and placing the implant. Or we can do bone condensation by bone tapping. So D1 is found in the anterior mandible, D2 is found in the anterior, posterior, and anterior maxilla. D3 is found in posterior mandible and anterior and posterior maxilla. D4 is only found in posterior maxilla. And so we have discussed about the basic anatomy, the theoretical part of the implants, and then the bone density. So we have concept of the physiology and anatomy. Then we know about what's the implant. The implant comes in a vial. Usually most of the implant companies comes in a vial. It's a sterile thing. So they will sterilize it and we get it in a vial. And this is a mounted implant. That means there is a mount to carry this implant into the patient mouth. And in some companies, this mount won't be there. It's a mountless implant. Various companies have various designs. And the design, these are the screws, that is the pitches or the threads of the implant. And this distance between each thread is a pitch. As the pitch or depth is increases, it becomes more active. And this is a cover screw. The cover screw is a small screw that's used to cover the implant once you place the implant. Then we have discussed about the implant. Then we have to know how we select a case and how we do the treatment planning for the implant placement. First is age of the patient. Usually patients above age 18 years is considered to be fit for implant therapy. If you do a implant placement in adolescent patients, the patient is in a growing age. So the placement of implant in this patient may affect the growth of the jaw on that side and it may lead to jaw disfigurement. The age of the growth completion, it may vary in males and females. In the females, or it may be around 16 to 17 years, and males it's around 17 to 18 years. And also regarding the minimal age, we have to decide the prosthetic options depending upon the age of the patient. If you are going for a young patient, we will give a fixed prosthesis, and the case for a older patient, we will give a prosthesis like overdenture, something like that for an older patient. And what are the medical conditions that we have to consider while we select a patient? We have to take a proper case history of the patient, and we have to address the medical problems of the patient. That is diabetes mellitus. Diabetes mellitus patients is cannot be considered as absolute contraindication of implant placement. But the blood glucose level of the patient should be under control. We should know about the HbA1c values, and it should be below 7. And we should be maintained priorly before the procedure for a period of 1 month, 3 to 4 weeks. That's about 1 month. And after the procedure, at least for a period of 6 months. Usually, it's better to keep the blood values under control for the lifetime. At least for the period of 6 months, it should be controlled, because the healing of the implant and the bone formation, everything takes place within a period of 3 months to 6 months. So during this period, patient should be cautioned. If the patient blood glucose level are elevated, there is chances of having periodontal infection and peri-implantitis. Hypertension. Hypertensive patients have a tendency to bleed more than normal because of the high vascular pressure. Hence, they should be operated only under controlled blood pressure conditions. And patients with thyroid disorders. Patients with thyroid disorders may be hypothyroidism or hyperthyroidism. In the case of patients with hyperthyroidism, there is chances of they are more susceptible to catecholamines or the adrenaline. So if you are going to give local anesthesia with adrenaline, there is chance of having tachycardia and increased perspiration, sweating, and patient may go into thyroid crisis. So it's better to give plain LA to patients with thyroid, hyperthyroidism or thyroid disorders. We should check the values of the patient, that is the T3, T4 and TSH values of the patient before the procedure, and then we should get a physician consent to do the procedure. and patients with bone disorders. Patients having any malignancy or any disease like Paget's disease or osteoporosis, if their condition is controlled, that is the blood calcium levels and everything is controlled, then we can go for implant placement. In the case of osteoporosis, the prognosis is poor. In the case of patients with bisphosphonates, we have to do the procedure. Or in the case of patients with bisphosphonates, it should be stored about 3 months before the procedure, and it should be not be continued at least 3 months after the procedure. In the case of patients with oral malignancy and osteoidonecrosis, in the case of patients with oral malignancy, they must have undergone radiotherapy. So there is reduced blood supply. So the healing, everything will be affected, and there is more chance of osteoarthritic necrosis. In these patients, the procedure should be delayed for a period of 6 months at least. Patients with liver cirrhosis. Patients with liver cirrhosis, there is more chance of bleeding as the clotting factors are affected. The formation of clotting factors are affected. And these patients, we have to get a physician consent, and then we should have a lookup of our clotting factors. And then if everything is normal, then we can proceed with the procedure. And we should not be also cautious about giving medication to the liver patients. Patients with angina pectoris and myocardial infarction. Patients with any cardiovascular accidents like angina pectoris or myocardial infarction. Mostly of the patients will be having any blood thinners like aspirin or warfarin. And in this patient, we have to get a physician consent, and we have to stop the drug before the procedure, and it should not be started after 1 to 2 days after. And patients with subacute bacterial endocarditis. In cases subacute bacterial endocarditis, we have to give antibiotic prophylaxis of 2 grams of amoxicillin before the procedure and 500 milligrams of amoxicillin half an hour after the procedure. And mainly it's given in the patients with the prosthetic heart valves, patients with any congenital heart diseases. And before doing the procedure, we had to do thorough oral hygiene, improvement of the oral hygiene with the scaling and rotating. Pregnancy, being an elective procedure, should not be done in pregnancy. Smoking, patients with smokers, there is poor prognosis for the patient implants. So in the case of smokers, there is reduced blood supply, healing is affected, bone formation is affected, there is lower chemotactic activity of the macrophages, there is lower phagocytic activity, and as a result of this, the implant prognosis is poor in the case of smokers. The habit of smoking should be stopped about 1 month before the procedure, and it's better to stop it. Or the patient should not continue it after the procedure also, once it gets healed. And it's better to give a antibiotic regimen of amoxicillin clavinate. 7-day course can be given. And also, if allergic to amoxicillin, we can give clindamycin or azithromycin, or cephalaxin or cefotraxil can be given. The rinsing of the oral mouth with oral rinse, fluorescein, is found to be helpful in reducing the chance of any infection. And it reduces failure rate from 13.5% to 4.5% in patients with type 2 diabetes mellitus. Studies have found that there is reduced chance of infection in cases where we are using the fluorescein mouth rinse 0.12% for after the procedure and before the procedure. And we should have a detailed examination of the patient for the arch form. We should know about the arch form, whether it is a U-shaped arch or V-shaped arch, to know our planning of the processes and ridge morphology of the edentulous region. We should know about the morphology of the edentulous region to know where there is any undercut is there or any we need any flattening of the surfaces. All these things needs to be considered before placing the implant. Soft tissue biotype. Soft tissue biotype. Some patients it may be having thin soft tissue biotype. In that case, we have to do grafting, soft tissue grafting after implant placement to increase the size of the soft tissue. So we will get a healthy gingival collar. Width of the keratinized soft tissue, we should have good width of keratinized soft tissue around the implant to have a good gingival collar. In cases where the keratinized soft tissue is less, we will have a connective tissue graft immediately after the procedure, or while we do the recovery of the implant and place the crown, we can do the increasing procedures, increasing the thickness of the soft tissue. And papilla at the implant site. In In the case of replacement of tooth in the anterior region, we have to preserve the papilla. And the incision that we place should be papilla preservation incision. If you cut we didn't preserve our papilla, the natural appearance won't be there. And the periodontal health of the adjacent tooth. The periodontal health of the adjacent tooth, we have to look into the consideration, because if the tooth near to the implant, either mesial or distal, is predominantly weak, it's having an active infection, the chances of failure of the implant is more. So we have to do scaling, root planing, and do the period treatment for the adjacent tooth and make it infection free, and then we should do the implant placement. Opposing an adjacent teeth at the occlusal position, we have to know about the occlusal clearance. Then only we will be able to plan the processes. There should not be at least a clearance of about 8 to 10 mm to place the prosthetic crown for the implant. Oral hygiene of the patient. Oral hygiene of patients should be better, not poor oral hygiene. Patients are not a candidate for implant placement, because if we place the implant, if the patient is not having any proper oral hygiene, he is not maintaining the oral hygiene, then there will be deposition of plaque and calculus. And alternately, this may lead to the form peri-implantitis and failure of the implant. Tobacco chewing and smoking, all these are negative factors that affected the health of the implant. These all habits has to be stopped before placing the implant. Bruxism. In bruxism patients, they are active chewers. The force transmitted to the implant will be more, and there is attrition of the tooth, and there is loss of vertical height in these patients. So we can consider the placement of night guards or bruxism guard in these patients to protect the implant. History of the diseased or lost teeth. We have to know about the history of disease or lost tooth to know whether there is any infection was there. If the patient was having an infection, periapical lesion, then we have to know about that, and then we have to clear that before placing the implant. Mouth opening. We have to do the osteotomy with the drill, with the handpiece, and everything in the patient's mouth. So adequate patient mouth opening should be there, because most of the companies release about 13 to 18 mm, and the size of the handpiece is about 1 mm, 1 centimeter. So it almost about 20-25. We can say about 20 millimeter. If we should have at least 25-30 millimeters of mouth opening, we won't be able to do the procedure in the patient's mouth. These are factors we have to consider while we do the oral examination of the patient in detail. So, CBC interpretation. So we have considered everything. We have taken the history. We have made the soft tissue profile. We have made the oral examination. Then we go for the radiological examination. Radiological examination of the implant placement, we can consider CBCT as a gold standard. We can do predict the quality of the bone. We can know the length of the bone. We can know the width of the bone, height. Everything can be measured from the CBCT. Here we can see that the measurement of crust of the width of the bone at the crust, and this red color thing is a nerve. We are able to mark the course of the nerve in each millimeter. These are 1 millimeter section. So in each millimeter section, we are able to get the length, maximum length from the crust to the nerve. So we can leave a space of about 2 mm to 3 mm from the nerve, and then we can place the implant. So if you have a CBCT, it's better to place the implant before starting our practice. So what are the key points for successful implant therapy? Implant diameter selection. Implant diameter selection should be done to get a good emergence profile and to avoid any screw loosening and any implant component or body fracture, and facilitate the oral hygiene. So if we have a available bone width of about 6 millimeter, we should keep about 1.5 mm all around the implant and place the implant. So we have to reduce it for about 3 mm. Then we can place 3 mm implants. But in the case of posteriors, as the occlusal load is more, we have to place a bigger diameter implant, at least about 4 millimeter. In the case of anteriors, we can place 3 mm. In the case of posteriors, we have to go for at least 4 mm. And implant length selection, maximum length, there's more stability, more implant contact with the bone. that is bone implant contact. So we have to place the implant with maximum length. And implant design connection selection, that is implant, earlier there was external hex, and nowadays we are having internal hex. Internal hex means the implant with the abutment or the prosthetic part. The abutment is a prosthetic part and it resembles a crown. It goes into the implant, into the internal hex. In external hex, the abutment goes onto the implant. That is all the difference. The hex is one thing, the hex is externally, that is onto the implant, and internal hex into the implant. That's all the difference. Usually we prefer the internal hex nowadays. Available bone width and bone height. And available bone height and bone width should be measured using radiographs like CBCT, and then we can leave about 1.5 mm all around and then decide our length. And in the case of if you are not having adequate length, adequate width of the bone, then we have to do bone augmentation procedures like bone grafting. And from the vital structures, we should leave at least about 2 to 3 mm. And in the case of maxilla, if you are not having enough height, then we have only two choices. One is bypass the maxillary sinus. The other one is we have to do sinus lift grafting and do the grafting. Then bone angulation. We have to know the angulation of the bone, and then we have to decide our placement. Distance between two adjacent implant or tooth. Distance between two adjacent implant is about 1.5 to 2 mm, and between two is about 3 mm, 2 to 3 mm. Minimal bone, that is buccal linga, 1.5 to 1 mm we have to keep at least. Implant distance from the mandibular canal, it's a vital structure. We should keep at least 2 mm to 3 mm for our safety in our initial practice. Distance to sinus or nasal floor, we should have a safe distance of 2 to 3 mm. Implant process occlusion, we have to check the implant process occlusion to avoid any lateral movements, and it should be and any axial loading of the implants. So if you place two implants all around, the space is about 1.5 implant, and in the case of two implants, this is 1.5, this is 1.5, and in between two implants, it should be 3 mm between two implants, and from the tooth, it's around 1.5 to 2 mm. All around the implant, it's around 1.5, and between two implants, it's about 2 to 3 mm. So we have selected the implant size, we have done the basic workup, we have done planned everything, then we can proceed with our implant placement. First, we have the first surgical step, and then comes the prosthetic step. It can be done in two methods. There is a delayed loading. That is, we will do the implant preparation, place the implant, and after a period of 3 months, we will take the impression like a crown and then deliver the process. That is delayed loading. And the other one is immediate loading. That we will place the implant, we will take the impression, and we will immediately give a temporary process. That is immediate loading. That's the two methods of placing implants. Surgical steps. In surgical steps, first one is we have to do open surgery. We will be making an incision over the crust. We will give a mid-crustal incision, and we will give a clavicular incision around the adjacent tooth, and we will give a vertical lacing incision only if necessary. And if we are giving a vertical lacing incision, the base should be wide than the apex. And in most of the cases, and in all cases, try to preserve this papilla. This papilla, all this papilla should be preserved. So your incision, vertical incision should be mesial or distal to the papilla. These are the factors that you have to consider. And you can use a 15 number blade to make the incision. And the other thing is, we have to use a clavicular incision. We can use a 11 or 12 number blade to give the clavicular incision. And when you use the blade, it should hit the bone, and then only you should move. So we have given the incision, and we have raised the flap. So we have the idea of the labial and lingual portions of the bone. So one thing is we can do freehand, or other thing is we can give a stent. That is, stent is like a but we can keep a tooth or a model which mimics the shape of the future tooth, and we can do the osteotomy according to that. Or else we can do free drilling with a pilot drill. Pilot drill is about 2 mm diameter, and we will make our initial depth, and we will check the parallelism with the adjacent tooth. Then after we will take the X-ray, we will check the parallelism with the adjacent tooth. Then we will deepen the drilling with the, suppose we are going for a 10 mm implant, we will do our preparation for a 10 mm using the depth pilot drill, 2 mm diameter. Then we will check the parallelism. So in the case of anteriors, it should be parallel to the adjacent tooth, and we should follow the shape of the bone. If you take the CVCT, you will be knowing about the cross section, and depending upon that, we will be able to plan our osteotomy. Then we will proceed with our depth piloting drills. That is, we are going with our pilot drill. Then next is 2. After 2, 2.8 or 2.5 varies from different implant systems. Then 3.2, 3.6, 4.2, like that. So the depth drilling and the osteotomy continues. So in the case of a low dense bone like a D3 or D4 bone, the case of maxilla, you are preparing for an implant of about 4.2 mm. You have to limit your preparation for about 3.6 mm. Otherwise, you won't get the primary stability. And in the case of a highly dense bone like D1, D2, like in the case of mandible, anterior mandible, if you have prepared for about 4.2, 3.6 and try to place a 4.2 implant, as the bone is highly dense, it will be very difficult to place the implant. So in that case, the shape of the implant is conical. You can think one thing you can do is, depending upon the site of preparation, we will decide our preparation width. In the case of D1 or D2 bone, we will prepare half with the 4.2 drill, and then we will place the implant. So we will get adequate primary stability. And after the final drill, we will check the depth using a depth gauge. Depth gauge is there. We can measure the depth that we have prepared. And here is a video of how we place the implant. It's a lower left mandibular molars. First, we will do the preparation of the site with the betadine or any antiseptic solution. We can scrub the site with the betadine, the intraoral and extraoral site. We can use a whole towel to cover the mouth if the patient is okay. And we need to clear the oral structures also. And we can give fluorescent mouth rinse also for clearing the oral cavity. And then we will give a inferior nerve block with a little bit of buccal infiltration. And then we need to give the incision. Incision is placed over the mid-crestal with the 15 number plate. We are giving clavicular incision, and then we will give a mid-crestal incision and hits the bone, and then we will be able to raise the flap. We are not given any vertical lacing incision. Instead, we have raised clavicular incision all around the premolars and the last molar to give a good flap without giving any vertical lacing incision. We are able to raise the flap. We can easily raise the flap. Yes, we can see the buccal walls and the lingual walls. Then we will do the pilot drilling. We will do the pilot drilling with the pilot drill. This is the pilot drill, about 2 mm to 2.5 mm diameter. We will do the pilot drill and we will place the parallel pin just to know whether the placement is parallel to the tooth. It's parallel to the tooth, and we can keep this pin here for doing our osteotomy of the second implant here. So it will help in guiding our drilling for the second implant. So parallel to this, we will place our second implant. We will do the preparation about 1.5 to 2 mm from the adjacent tooth and 3 mm between the implant. We have prepared. we have attained our depth. Then we will check the parallelism, and then we will take the X-ray and we will proceed with our depth drilling. We are going to do our preparation sequentially. All drills we will go for the preparation. As it is mandible, we will go up to the size we are placing the implant. Yes, we have enlarged the site. We are using the depth probe. This is the depth probe. You can see the osteotomy site. 2 osteotomy sites are there. We are using the depth probe. We can measure the depth of the osteotomy, and this is the osteotomy site that we have prepared. 2 osteotomy sites are there to receive the implants. Final drilling of the cervical region. Just for this is the packaging of the implants. This is a vial, and this is the cover screw to place over the implant. So this is a mountless implant. It does not have any mount. So we have an implant driver, and using this driver, we will lift the implant from the sterile vial and we will place it directly onto the patient's mouth. Yes, we have, and then we will torque it using a torque wrench. This is the implant driver. We have placed the implant onto the patient's mouth. Sorry. Yes, then we are torquing the implant with a torque wrench that is used to torque the implant into the bone. So we will place the implant just below the cervical level of the bone. So we are torquing it finally, and once it is finished, we will take the X-ray just to check the position, and then if possible, we will torque it a little bit more down to keep it subcrustally, just below the crust of the bone. This is another implant. This is also a mountless implant. Here no mount is there. We will place a driver over it, that is the implant driver, and then we will place the implant onto the osteotomy site, and then we will use our torque wrench to place the implant into the socket. This is the cover screw. This is a hex driver used to remove the cover screw, the abutment, all components we can remove. Small components we can remove this with this hex driver. We will cover this is a delayed loading case. So we have placed the cover screw and we will give watertight closure using a 3/0 silk or a 3/0 vicryl. And this is the X-ray of the implant. 2 implants are parallel. We have placed a little bit subcrustally. This is a little bit subcrustally and it's almost under the crust. And this is how we do the packaging and everything. This is how we place the implant. And once we place the implant, we will remove the cover screw and we will place the cover screw over the implant and we will close it and we will do the primary closure with the sutures. And in the delayed loading protocol, after a period of 3 months, we will uncover the implant by placing using a tissue punch, or we can place using a 15mm blade and place a small plus shaped incision, and we can use our hex driver to remove the cover screw and we will place a gingival healing collar. The gingival healing collar is a component that is used to get the gingiva around the implant, so it will have a good gingival collar, and we will keep it for a period of about 2 weeks. And after 2 weeks, we will remove this gingival healing collar and we will place the impression post. The impression post is a component that is placed to replicate the position of the implant in the impression. And this impression post is of 2 types. That is, one is open thread impression technique and the other is closed thread impression technique. And we will place this impression post, and using addition silicone, we will make the impression. And once we make the impression, we will get the indentation of this impression post in the implant, the addition silicone impression. Then we will remove this one and place a gingival healing collar into the implant. And this gingival impression post will be connected to a lab analog of the implant. Lab analog is a process or a component for the lab to mimic the position of the implant in the cast. Understood? So we will connect the impression post with the lab analog and it is placed into the impression and we will send it to the lab. Then the lab will make the processes for the cast. Then we will have the impression post, the impression lab analog in the cast and the impression post outside the cast. So we got the position of the implant in the jaw in the cast. Then we will place our abutment instead of that impression post and then we will make our process over that. And once we get the processes, we can get it either like a cement return like our normal crowns or screw return. This fixed using screws into the patient's mouth. And usually the impression techniques are of two types. That is, one is open tray, other one is closed tray. In closed tray, that is the one we explained earlier. That is, the tray is closed. The length of the impression post is less. In open tray, the length of the impression post is more. So we have to prepare one hole over the impression tray. And then when we take the impression using this addition silicone, the impression post may project out from the patient's mouth. So you can use the hex driver to remove this impression post and we can remove the impression. Like that in closed tray, the impression post is in the impression. We haven't removed it. In closed tray, we will remove it from the patient's mouth and we are the person who are inserting into the impression, the lab analog and everything. So if in some companies the impression may be not that much accurate. So if in something happens, there is chance of errors. And in this method, we take the impression and do the process. And what are the recent advances in the case of implant? Sinus grafting. In the cases where there is a length of bone is less in the case of maxillary posteriors, we can do the sinus grafting. This is a sinus membrane. We can elevate the sinus membrane by a lateral window. That is, we prepare a window on the lateral surface of the sinus wall. We will elevate the membrane and we will graft it and we will place the implant. And the other one is crustal approach. That is, we will approach from here, from the crust. We will do the osteotomy and there are specialized equipments to lift the membrane through this crust only. And we will do the grafting and then we can place the implant. We should not load the implant in this case. Then zygomatic implants. In cases where there is severely atrophied ridges are there, we can use zygomatic implants and tuberotergoid implants or pterygoid implants. We can bypass the sinus membrane and then we can place the implant. The implant is placed onto the zygoma. That is, we have the zygomatic process of maxilla. The implant is inserted from the oral cavity into the sinus wall. So it will, as you see, this is the zygomatic arch. As you can see that this is the zygomatic arch. From here, we will make a groove over the sinus wall and then we will reach the zygomatic arch and then the implant is placed into the zygomatic arch. It has high primary stability. This is technique sensitive. You can see that the implant enters the zygomatic arch. This is the zygomatic arch. It enters the zygomatic arch along the sinus. Tuberotergoid implants. Tuberotergoid implants, the implants are placed onto the pterygoid. Here we can see that the pterygoid plate. We will do the osteotomy a little bit from the distally and buccally from the maxillary tuberosity region, and it enters the pterygoid plate, and the implant is inserted into the pterygoid plate. It also has a high primary stability, but it's a little bit technique sensitive. And in the case of maxillary atrophied ridges, we can place the implant like this in the case of lateral nasal region and pterygoid and do the replacement of the tooth. And also with the advent of digital impressions and the digital dentistry workflow, we are able to predict the implant placement and we can do stents can be prepared and we can place the implant without any errors. These are all the recent advances with the implant. As the technology advances, the implant placement becomes more ease. And we can do the preparation and everything at ease without any risk. Thank you. By this, we come to the end of the session. Thank you very much. Over to you. If you have any doubts, you can share with me.
Thank you so much, sir, for this amazing session. So I request all the participants, if you have any doubts, you can drop your questions in the question and answer box. And meanwhile, I will be introducing all our participants to our organization. So this is our channel, DentistChannel.Online, with the motto "Healthy Smiles that leads to wealthy lives." So I request all the participants to kindly make a note of this website, www.dentistchannel.online, and you can find anything and everything which is related to dentistry. Basically, we are a digital dental marketing company that is striving very hard to bring all the dental practitioners and dental media companies and dental companies under one roof and creating opportunities for everyone. And we conduct a lot of webinars and workshops every week. So I request all the participants, if you have subscribed to our Prime membership, you can avail a lot of benefits. Like you'll be getting certificates, e-certificate for each and every webinar that you attend. You will be gaining a lot of discounts for the workshop enrollment. So this is one sample certificate. Okay, so I request all the participants to kindly take a screenshot of the slide and save this number and send your name as a text message on this number, and you will be added to our broadcast list so that you are updated regarding each and every upcoming events that we have. This is one dental implant company. You can know more by visiting on www.novamind.gmbh. For all the recorded videos, if you have missed out on our live sessions, you can always go back to our recorded videos on Facebook and YouTube. Plus, you can follow us on Instagram, and you will be updated regarding each and every upcoming events or anything that we have. So you can search us with the handle DentistChannel.Online. Okay, so let's move on to the question and answer session. We have our first question from Dr. Abhinav. He's asking for single implants, which is preferred, submerged or one which is exposed cover screw in oral cavity.
Submerged or one with exposed cover screw in the oral cavity. That is in single implant or multiple implant. If you are able to get the submerge the implant, that is, we have to place the implant subcrustally. If you are able to place the implant subcrustally 1 or 2 mm, it's better. And in any cases, we are not exposing the cover screw in the oral cavity. Once we place the cover screw, we will, in the case of delayed healing protocol, we will suture the wound with a primary tight closure. This submerging concept means we will submerge the implant about 1 mm or 2 mm into the bone. So once any crustal bone loss is there, we have to expect crustal bone loss of about 1 millimeter over a period of time. So if we are placing the implant 1 mm or 2 mm subcrustally, we will get a good amount of bone crustally post processes. That is the concept of submerging the implant. That is, we will place the implant 1 to mm subcrustally into the bone. And if you place the implant over the crust or at the level of the crust, we will cover it up with the cover screw and we will do the closure of the soft tissue. So it's not exposed to the oral cavity.
Right. So before winding up the session, any takeaway note for our participants, sir?
Implant practice can be done with by anyone, but you have to get at least the basic knowledge to do the implant practice. It's not a big deal to do the implant practice. Single implants or multiple implants, any dental graduates can do the dental implant practice, but we have to know the basic factors or the basic knowledge of the implant practice, and then we have to do the implant practice. The only main thing is anatomy and the basic factors of the implant. And
Okay.
all these companies and everything that we have to consider it once we start the implant practice. First, we start with the implant practice, then only we will be able to do it. But doing the FPD is more easy when compared to the doing an implant. But when we do an implant, we are not reducing a good tooth. For replacing one tooth, we are not reducing the enamel and the two substance of tooth. And we are not
Right.
giving
The other natural tooth is not compromised.
Yes, not compromise. In the case of a patient having no tooth, edentulous, completely edentulous, if we are able to give a overdenture to the patient, will be very helpful to the patient. Instead of giving a normal CD, if you are able to place 2 implants and give a overdenture, patient will be very happy. The only thing we have to know is it's easy. Basically, if you know the concepts, everyone can place implants. And
basically, we are delivering quality of life with implants.
We are the quality of the life is increased. Patient will be able to chew food, and patient will be happy once he is able to have all the food that he likes, unless having very soft food.
Right. So on this note, I again
we are having our courses.
Yeah.
We are having our courses in Kerala, and we are doing it on a regular basis in 2 months, and in Kochi. And our upcoming course is from 6th to 9th of Jan. And you will get the details from Dr. Aditi.
Yes, I request all the participants, you can visit our website and you can find all the details regarding this comprehensive implantology course for 4 days. It is starting from 6th of January till 9th of January. You can visit our website and find all the details there. So with this, we'll be ending our session. Thank you so much, Dr. Anuj, for joining us for this very informative session on implantology. So thank you so much to all the participants who have joined us. So with this, we are ending the session. Good night and take care.
Thank you very much. Thank you.